And we will now have the next session from none other than Dr. A.K. Singh, who is such a well-known figure, especially when it comes to research and meta-analysis and different drug reviews. So I would be chairing this session. And Dr. Abdesh Kumar Singh, everyone knows him. He's been a very successful endocrinologist for the last 18 years. And he is the chief endocrinologist and diabetologist at GD Hospital and Diabetes Institute, Kolkata, and Sun Valley Diabetes Hospital, Guwahati. And he is going to be talking on the evolving evidence with newer DPP-4 inhibitors. So we shall now have a recorded session from Dr. A.K. Singh.
Thank you, Team IDEG, Dr. Sanjay, Neeta, and entire team. So my job is to take you through the promise and potential of a new DPP-4 inhibitor, that is Evocliptin. Remember, this session is sponsored by Evocliptin maker in India, that is Alke. Now, what is this new DPP-4 inhibitor is all about? Let's go through the data of Evocliptin. So Evocliptin is a highly selective and a very potent reversible inhibitor of DPP-4 enzyme. And it has been extensively studied with regard to their phase 3 program that studied efficacy and safety of Evocliptin. On your right hand side, you can see the approval of Evocliptin initially in the Korea. It is available in the name of Suganon, and it was approved in South Korea in 2014. And followed by, it was approved in various countries, including Russia and India in August 2018. Right now, Evocliptin has got a prescribing information to be used in the treatment of type 2 diabetes as an adjunct to diet and exercise to improve glycemic control when you used as a monotherapy or in combination of metformin. Now, where from this indication came for the Evocliptin? What is the evidence for 5 milligram once daily Evocliptin in the treatment of type 2 diabetes? Now, let's look into some of the pharmacokinetic and dynamic properties of Evocliptin. As you all know, DPP-4 inhibitors blocks the DPP-4 enzyme on various, anchors. As you can see, there are 5 anchors. The primary one is S1 and S2 anchor associated with one large S2 extensive anchor for DPP-4 to get attached with the enzymes. And there are some additional anchors like S1 prime and S2 prime. When you talk about DPP-4 inhibitor, different DPP-4 inhibitor anchors through either 1, 2, or 3 of these anchors, in the DPP-4 enzyme substrate. Now, the fundamental requirement for all DPP-4 inhibitor that it must anchor to S1 and S2. Now, if any DPP-4 inhibitor has additional anchoring ability, this would allow the DPP-4 inhibitors to firmly adherent to the DPP-4 enzymes so that it produce a sustained DPP-4 inhibition. And on the basis of these binding, DPP-4 inhibitor has been classified into class 2 and class 3. All these are arbitrary definition based on X-ray crystallography, on the binding mechanism to the DPP-4 substrate. Now, as I said, some of these DPP-4 inhibitor additionally bind to either S2 extensive or S1 and S2 prime. But fundamentally, everyone has to get stacked to S1 and S2. 3 DPP-4 inhibitor like sitagliptin, teneligliptin, and evocliptin, they have been classified into class 3 type of DPP-4 inhibitor because they additionally bind to S2 extensive substrate other than S1 and S2. The other DPP-4 inhibitor, they bind to either S1 prime or S2 prime, but they do not bind to S2 extensive. Now, the beauty with S2 extensive theoretically suggests that if you bind to an additional anchor like S2 extensive, the DPP-4 inhibitor tends to have a very firm binding. Now, the exception is always in the rule, although tenaligliptin belongs to this class 3 because it gets, attached to S2 extensive. DPP-4 inhibition ability of tenaligliptin is meager among all the DPP-4 inhibitors. And if you look into the data of DPP-4 inhibition, which will come later on, the tenaligliptin binds as much as 65% as opposed to sitagliptin that binds to DPP-4 by almost 97%, and so is evocliptin by more than 90%. So not necessarily these theoretical disposition will fundamentally lead to a really robust DPP-4 inhibition. Well then, now as a clinician, we are interested whether these binding translates into any clinical benefit, if at all a particular DPP-4 inhibitor has this ability to bind to additional anchor. Now, when it comes to selectivity and potency, this evocliptin, look here, has got ability to DPP-4 versus DPP-8 and 9, very selectively. And if you compare with other DPP-4 inhibitor, it is apparent that evocliptin seems to be a very specific DPP-4 inhibitor, unlike vildagliptin, unlike tenaligliptin, or even sexagliptin. Now, if you see the potency of the drug evocliptin, it is as potent as, and perhaps most potent, very closely equal to linagliptin, and with the DPP-4 inhibition of IC50 of 1 nm, as you can appreciate evocliptin, and therefore the potency of evocliptin is the best among all the DPP-4 inhibitor in the line of linagliptin. Both linagliptin and evocliptin is used in 5 milligram dose, as you can appreciate, as opposed to larger dose of other DPP, for example, 100 milligram of vildagliptin or 100 milligram of sitagliptin, but not necessarily potency. A better potency always leads to a better efficacy. However, in potency, as you can appreciate, evocliptin is a very potent DPP-4 inhibitor, as well as a very selective to DPP-4 versus DPP-8 and 9. Remember, we don't want to inhibit DPP-8 and 9 while trying to achieve glucose control. It's the DPP-4 inhibition that is responsible for glucose control without any adverse event. If you block DPP-8 and 9 by a non-specific DPP-4 inhibitor, you tend to have many more, off-target side effects of DPP-4. And the example lies with vildagliptin and sexagliptin, which are non-specific, with regard to DPP-4, and they do have many unwanted side effects. For example, vildagliptin has got the highest potential of a skin reaction. In the same way, sexagliptin causes, lymphopenia, that is there in the trial and there on their prescribing level. So we need a very specific DPP-4 inhibitor which don't have much action on DPP-8 and 9. Now, with regard to the pharmacokinetic, as you all know, some of the DPP-4 inhibitor is primarily excreted through kidney, and therefore their dose needs to be reduced in patients with chronic kidney disease according to the EGFR, such as sitagliptin and vildagliptin, so as the sexagliptin. The linagliptin is one exception because it is primarily excreted through biliary route, and you don't need to reduce the dose of linagliptin in patients with CKD. Both tenaligliptin and evocliptin are, equally excreted through liver and kidney, and therefore even these two DPP-4 inhibitor dose requirement is not necessary in people with chronic kidney disease or even a chronic liver disease. And I will explain you how this data came into the picture. So in the class of DPP-4 inhibitor, it's not only linagliptin where you don't need to reduce the dose in patients with CKD, it is also with tenaligliptin and evocliptin. But remember, the data for both tenaligliptin and evocliptin in patients with CKD is very small. Nonetheless, whatever data is available, that recommends that Evocliptin can be used without any dose alteration, irrespective of the EGFR. Now, where from this data came from? The data came from this study, although, as I said, pretty small study done in patients with various grade of kidney dysfunction, and it was found that there is no increased excess in the therapeutic concentration with the current dose of Evocliptin, and therefore this study concluded that you don't need to reduce the dose of Evocliptin in patients with various degree of kidney dysfunction. The similar data is with the Evocliptin in patients with liver disease. Again, the caveat is these are very small studies at the moment, but this study in patients with hepatic impairment did suggest that there was no excess therapeutic concentration with a various degree of hepatic dysfunction, therefore suggesting that you don't need to alter the dose of Evocliptin in moderate hepatic impairment. Remember, none of the DPP-4 inhibitor is currently considered in people with severe hepatic impairment. Well then, now let's come into the clinical data. As a clinician, we need the good efficacy and safety data. The Evocliptin, I would tell you, and I can tell you with confidence, is one of the DPP-4 inhibitor, or rather a low-cost DPP-4 inhibitor, which came into the market, with a robust data. Now, I don't want to bore you with all those studies, but this slide suggests you that how many trials have been there with Evocliptin before it got approval, and many more trials are still under progress. And I'm hoping that in the next couple of years we may have even a better evidence available with Evocliptin in type 2 diabetes. However, I have picked up 6 landmark studies of Evocliptin that needs attention very quickly. Now, as I said, this is one of the low-cost DPP-4 inhibitor that attracted me because of their robust data. And these data are not published in any XYZ journal, but these data are published in one of the highest impact factor in the world. So you have got 3 blue colored study and 3 purple colored studies, so total 6 studies in front of you. What is interesting to note that the first 3 studies are study done in patients who were drug naive. So it is a monotherapy trial. The first one is trial conducted against placebo, and from this trial result they got approval in South Korea in 2013-14. And the next 2 trials are the trials of Evocliptin that was done as a monotherapy in a drug naive type 2 diabetic patient and compared head-on to active comparator. So you can see the second trial was a head-to-head trial with sitagliptin, and the third monotherapy trial was a head-to-head trial with linagliptin. It's called Evergreen Study, where Evocliptin was head-on compared to the linagliptin, not only to the HbA1c, but also on a glycemic variability account. Remember, all these papers have been published in a good high-impact journal. The next 3 study was done in patients with type 2 diabetes who were receiving metformin and then were either added Evocliptin or sitagliptin. You can see all the last 3 studies are head-to-head study with sitagliptin in a background metformin therapy. So out of 6, these trials and landmark trial, the 5 trials are a head-to-head active compared trial. Unlike other, low-cost DPP-4 inhibitor, which is available in the market, which came and got the DCGI approval in absence of any head-to-head trial with a standard care of drug like a sitagliptin comparison, which all other, US FDA approved drug has got approval because of their head-to-head trial showing non-inferiority. So that's the beauty and the confidence, at least to me, gave when I look into these 5 head-to-head trials with one of the standard DPP-4 inhibitors, that is sitagliptin. Now, let me quickly go through these 6 trials in a one-slide agenda. So the first trial, as I suggested, was the head-to-head trial versus placebo in a drug-naive patient as monotherapy. And this trial got published in Diabetes, Obesity, Metabolism, as you can appreciate. And Evocliptin was found to have a significant HbA1c lowering compared to placebo. Now, these HbA1c lowering was different depending upon the baseline. So someone having HbA1c of more than 7.5% had a roughly 0.7% reduction, whereas someone with HbA1c of less than 7.5 at the baseline had 0.2% HbA1c. And we always saw this kind of HbA1c change if the baseline HbA1c is different. Overall, if you combine the data, there was 0.5% HbA1c reduction against placebo in this monotherapy trial. And on the basis of this particular trial, the Evocliptin got approval in the South Korea. The second trial, this is a bridging trial which happened in Russia. And in this trial, Evocliptin was compared head-on to the sitagliptin. As you can see, this is a 12-week trial with a 3 different doses of Evocliptin compared head-on to the sitagliptin. Remind you, these are double-blind, randomized controlled trial. And you can see in the 2 doses of Evocliptin, 5 milligram and 10 milligram, HbA1c lowering versus sitagliptin was non-inferior, that both sitagliptin and Evocliptin had a similar HbA1c lowering in this double-blind randomized controlled trial. The third study, which is called Evergreen Study, again, this is a double-blind randomized controlled trial in treatment-naive type 2 diabetic patient where Evocliptin was compared head-on to the linagliptin. You can see this is a single-blind trial. For the initial 12 weeks, it was double-blind, and then it was the open level. And the head-on Evocliptin 5 milligram was compared with linagliptin in roughly 100 patients. It was measured not only on the HbA1c, but also on a continuous glucose monitoring system. Now, if you look into the result of this trial, both on HbA1c and difference in glycemic variability, it was interesting to find that Evocliptin was as good as linagliptin with regard to the HbA1c lowering. Now, numerically, in fact, Evocliptin arm had little better HbA1c reduction. However, it wasn't statistically significant, thereby suggesting that both Evocliptin and linagliptin had similar HbA1c lowering at the end of 3 months in this double-blind 12 weeks randomized controlled trial. If you see the percentage of people achieving the HbA1c target of less than 7% or 6.5%, you can find out it's pretty similar, thereby suggesting that Evocliptin is as good as linagliptin when it comes to glucose control. What was even more surprising was on the glycemic variability. Now, this study, Evergreen, did find a numerical better glycemic variability reduction with Evocliptin compared with linagliptin, although it did not achieve a statistical significance, suggesting that Evocliptin is as good as linagliptin in reducing glycemic variability in whatever way you measure, either by mean amplitude of glucose excursion or by the change in standard deviation. There was no difference whatsoever, or if at all any difference was there, it was numerically better with Evocliptin compared to linagliptin. So these are the 3 monotherapy trials, of which 2 head-on trial with sitagliptin and linagliptin that found Evocliptin as good as a 2 standard of care when it comes to DPP4 like sitagliptin and linagliptin. Now let's look into the other 3 trials, which was done in a background metformin therapy, and surprisingly, all these 3 background metformin trial of combining or a fixed dose combination of Evocliptin and metformin versus either a sitagliptin and metformin was very interesting. So this is a first head-to-head trial. This is a Korean study, and it is again double-blind randomized controlled trial, 6-month trial comparing Evocliptin to sitagliptin in a background metformin therapy, and you find no difference in HbA1c between 2 DPP4 inhibitors. although numerically sitagliptin had little bit better HbA1c at the end of 6 months, but then it did not achieve a statistic, thereby suggesting that in a background metformin therapy, evocliptin and sitagliptin did a similar glucose block. The second study is an Indian study, and you can see this is called Evolution India study. And again, it was done in a background metformin therapy. Look at the quality of the trial. These all are double-blind randomized controlled trial and published in one of the best journals in the world. And in this trial, in Indian population, again, there was no difference in HbA1c lowering between sitagliptin and evocliptin in a background metformin therapy. So that's the fifth head-to-head evidence with evocliptin when comparing either with sitagliptin or linagliptin. Finally, this is a study again compared evocliptin to sitagliptin. This is a Russian and Korean trial. You can see here, and this trial is again a double-blind randomized controlled trial comparing evocliptin to sitagliptin in a background metformin therapy, and they find no difference in HbA1c control. So, ladies and gentlemen, out of 6 trial which I have shown you, in the 5 head-to-head trial, 4 versus sitagliptin and 1 versus linagliptin, evocliptin was non-inferior to both the active competitor. Now then, how to choose? Now, in the Indian context, this is a very interesting slide, and this is my slides, and this is my understanding while looking into all DPP-4 inhibitor and choosing amongst the DPP-4 inhibitor. Now, so when it comes to the Indian context, we have got this 7 DPP-4 inhibitor right now in India: Sita, Lina, Sexa, Allo, Vilda, Tenaligliptin, and Evocliptin. Let's closely look into each data, separately. Remember, these are the trials which has not been done in a head-on fashion, so you can't exactly compare, that A is better than B. However, these trials were done in a different setting and does merit indirect comparison. Now, if you look into a percentage of DPP-4 inhibition, which is the crux of the glucose control pharmacokinetically, so amongst the different DPP-4 inhibitor, it is clearly apparent that the 2 DPP-4 inhibitor which has got perhaps the least DPP-4 inhibition is tenaligliptin, and which is pretty close to sexagliptin. I can tell you that there were 2 head-to-head trials of sexagliptin versus sitagliptin, and where in one trial the sexagliptin was found to be inferior to sitagliptin. So we do have some evidence with the sexa versus sita, and thereby suggesting that the DPP-4 inhibition does matter when it comes to glucose. So you can make out that these 2 DPP-4 inhibitor, tenali and sexa, has got least DPP-4 inhibition with a therapeutic licensed dose. The second important point while choosing DPP-4 is the DPP-4 selectivity, because we don't want to have the off-level target of DPP-4 inhibition. DPP-4, DPP enzymes are ubiquitous, and there are many DPP enzymes which is good for the human being. So if you block all the DPP enzymes, you may have a harm, with the drug, and therefore we need a selective DPP-4 inhibitor. Remember, treatment of type 2 diabetes is a lifelong business. So you need to have a drug which should not produce any unwanted or off-target side effects. And therefore, we need a very selective DPP-4 inhibitor. We don't want to inhibit any other DPP enzyme other than DPP-4. And therefore, the selectivity plays a major role. Now, if you look into different DPP-4 inhibitors, as I said in very beginning, sexagliptin and vildagliptin in particular has got a very least selectivity to DPP-4. And many people claim because of this, non-selectivity, vildagliptin has got a highest skin eruption and the, dermatological side effects. And similarly, sexagliptin has got some unwanted WBC abnormality, which is there in the prescribing level of sexagliptin. Now, if you look into the dosing, of course, dose matters in the patient compliance, and we prefer to have a once daily tablet rather than a 2 dose of tablet. Here, the vildagliptin perhaps has got some disadvantage because it should be used in twice daily dose. The fourth important point is whether you need to alter the dose of the drug. Yes, there are, as I suggested in very beginning, there are a few DPP-4 inhibitors where their dose needs to be reduced as per EGFR, and some do not require. In the no require dose adjustment list, the linagliptin comes at the top with the highest data, and both tenaligliptin and evocliptin also has got a current prescribing information that you don't need to reduce the dose in patients with renal disease, irrespective of the baseline EGFR. The liver disease, here lies the catch. As we all know, vildagliptin is not at all allowed in any degree of liver insufficiency. So vildagliptin is totally out. Of course, in severe liver dysfunction, this child POF class C, we don't recommend any drug. And you can use any other DPP-4 inhibitor other than vildagliptin in child POF A and B class. HbA1c lowering, very important and perhaps most important for clinician like us. If you see the active comparator trial, we do have some reference. If you take sitagliptin as an active comparator trial, we do have head-to-head trial with different DPP-4 inhibitor. Linagliptin, sitagliptin has got nearly similar HbA1c lowering. In one of the trial, linagliptin showed inferior HbA1c lowering compared to sitagliptin. Now, we do have head-to-head trial also, as I shown you with evocliptin. We do have one trial now with tenaligliptin versus sitagliptin showing a similar HbA1c low. So basically, all DPP-4 inhibitor, in one hand has got more or less similar HbA1c lowering ability, when in comparison. There might be slight 0.1, 0.2% difference with drug A versus B, but by and large, the HbA1c lowering with all DPP-4 inhibitors are same. Now let's come to the safety part. So the last three, row is for safety, and what are those important points is QT prolongation. It's a mandate that all diabetic drugs has to undergo a mandatory QT prolongation trial in a supraphysiological dose, and ideally should be compared with moxifloxacin, because the moxifloxacin is an ideal drug to compare the QT prolongation, because that is the drug which causes highest QT prolongation among all pharmacotherapy in the treatment of human beings. So you need to conduct a head-to-head trial versus of DPP-4 inhibitor. Now, if you look the data, we do have studies which has been done with different DPP-4 inhibitor. Amongst all the DPP-4 inhibitor, tenaligliptin was found to have a QT prolongation, as you all know, and Japanese PMDA gave them approval and suggested them to conduct a dedicated cardiovascular outcome trial. Unfortunately, tenaligliptin do not have any cardiovascular outcome trial to know whether the QT prolongation seen in comparison with moxifloxacin has got any deleterious effect on the cardiovascular system. Cardiovascular safety, very important. In today's era, we don't need any drug which is not cardiovascular safe. Unfortunately, not all DPP-4 inhibitor has undergone mandatory cardiovascular safety outcome trials. And the initial 4 drugs, sita, lina, sexa, and elogliptin, has undergone their respective cardiovascular outcome trial, and they all were found to have a cardiovascular neutrality, except that sexagliptin had a significant signal of increase in heart failure. The allogliptin data is controversial, so that's why I put it in a capital, and this one, in the smaller font. The reason being that allogliptin data is controversial. I feel the allogliptin heart failure was unfortunate. There were some increase in heart failure, but with allogliptin, but it was not statistically significant. So it was unfortunate to club allogliptin in the heart failure causing DPP-4 inhibitor. However, still in the United States, they have got a warning for the allogliptin in a similar fashion like allogliptin. The last three DPP-4 inhibitor, neither Vilda nor Denali or Evocliptin has undergone the cardiovascular safety outcome trial. So therefore, we don't know exactly whether they are cardiovascular neutral. And finally, in the Indian context, the cost plays a major role. Now, the initial 4 DPP-4 inhibitor that underwent a cardiovascular outcome trial, they are a costly drug, barring the allogliptin, because a generic allogliptin is available in India. That's why it's a cheaper, DPP-4 inhibitor. Now, if you look the last 3 DPP-4 inhibitor, these are the cheaper versions of DPP inhibitor in India. So if you look at this table where this all endpoint looks to be in general fine. To me, Evocliptin has got a case to make here, and you can see this is a DPP-4 inhibitor which is pretty cheap, available in India, which can be given in a once daily dose, which has got several head-to-head trials having a similar HbA1c lowering like sitagliptin, which can be used in a once daily dose. It doesn't need any dose requirement in people having a different degree of renal and hepatic dysfunction. The only issue which is there with Evocliptin is at the moment is they don't have cardiovascular outcome trial, yet they do not show any QT prolongation, unlike tenaligliptin. So here is the case that Evocliptin seems to be one of the good contender amongst all the cheaper versions of DPP-4 inhibitor which is available. I hope I was enough to give you the entirety of evidence which is available with the Evocliptin. The choice lies with your company and the evidence which is available with the Evocliptin. Very much for your patience listening. And thank you, organizer, again for inviting me for this.
We are very thankful to Dr. A.K. Singh for giving us this recorded version